Most of the surgeries that I do take anywhere between 1 and 3 hours to perform. It may seem like a lot longer to the family waiting for their child to finish, just because there's lots of things that we have to do when we're back there to get the child cleaned up, get them on the table, get them off the table when we're done, get their dressings on and so forth. Other things that happen back there is our anesthesia colleagues help us out by doing what's called a nerve block or a regional anesthetic. This is where they give an injection or a shot into a certain part of the arm or the certain part of the leg to help numb up the extremity, to help us do our procedure a little bit easier, but also to keep your child comfortable when they go home. They usually get to the recovery room and feel pretty numb. That numbness does wear off in about 6 to 8 hours. So that's also why we send you home with pain medications. Most kids that I do surgery on get three medications. They're going to get a narcotic, either Vicodin or Percocet. They're going to get a strong prescription strength anti-inflammatory that we call Toradol or Ketorolac. And they also get something called Zofran in case their belly gets upset or they get nauseous. Now, the cool thing is these medications, I always prescribe them to our pharmacy in the hospital, as long as your insurance will cover it. And that pharmacy is on the first floor and it opens at 9 a.m. So if you have a morning surgery, anywhere around 10 a.m. and afterwards, you can go down there and pick it up as long as you have a form of payment and an ID. These medications are as needed. Your child does not have to take any of them, to be honest with you. But we do send your child home with these medications because we know that surgery can be uncomfortable. And eventually, that nerve block or the regional anesthetic that we use is going to wear off. Your child will probably go home with crutches if they're having a leg surgery. Depending on what specifically we do, we may have to keep them off of their leg. But some surgeries, we do let them put a little bit of weight on it with the crutches. They usually have an ice machine and a brace for most leg surgeries. If it's an upper extremity surgery, it's usually just an ice machine. And when the surgery is over, I usually come to the recovery room and talk to you and let you know how everything went. And I'll show you how to use the brace. I'll show you how to use the ice machine. And the nurses in the recovery room will go over all of that stuff as well, both physically and also by giving you a set of detailed instructions. After the surgery is done and I talk to you in the recovery room and your child is stable and you get all of your post-operative medications and your instructions and you know how to use everything, then we usually send you home. Most of my kids don't have to be admitted to the hospital, which is nice. And my secretary should have or will schedule a post-operative appointment for you, usually in about 5 to 7 days after surgery, so we can see your child again, so we can look at their wounds and get them started in physical therapy. And depending on the kind of surgery you had and the complexity of the surgery, what we also offer now are virtual visits or telemedicine visits, where you actually don't have to come back to the office to be seen. You can do it from home, similar to like doing FaceTime with somebody or doing a Skype video with somebody. That way we can see your wounds, we can talk to you, we can have you bend your knee or bend your elbow or move your shoulder, depending on where your surgery was. And that may save you some time and energy in coming to the office. And we can fax you or email you all the necessary prescriptions that we use as well. This is very helpful for folks that live either downstate or very far away, but also for people who've had very simple minor procedures where we don't necessarily have to see them back. So for those of you that are having patella instability surgery or surgery for a dislocating kneecap, what we typically do is what's called a medial patellofemoral ligament reconstruction or an MPFL surgery. So the first thing we do after you go to sleep is we do what's called a diagnostic arthroscopy, where we put a camera inside of your knee and we basically look around at all the cartilage structures, the ligaments, your meniscus pads, and we see what kind of damage may or may not have been caused by your kneecap continuously popping out of place. If there's any work that we need to do in there, we often smooth out some of the cartilage and maybe release some tissue to make your kneecap glide a little better. But that part of the procedure probably takes about 5 or 10 minutes. After that, depending on the severity of your issue and your instability, sometimes we cut your shin bone and move a piece of the bone a little bit over to the side, also to help the alignment of your lower extremity or your leg and help your kneecap glide a little bit better. Usually, when we cut this part of the bone, we fix it with a couple of screws, probably two or three of them, to hold things in place. And the last part of the procedure is where we actually take your kneecap and we anchor it down to your thigh bone. That's the medial patellofemoral ligament reconstruction proper. We usually use a piece of tissue or a graft that comes from someone or for someone else called an allograft, and we anchor that as well with a couple of small screws, one into your kneecap and one into your thigh bone. So, in terms of complications of this surgery, these are some of the things that we do think about after you have a MPFL reconstruction. First thing is stiffness. So, a lot of times after a procedure, you may be scared, you may be in pain, you may be anxious. So, your knee does have a possibility of getting stiff. So, we usually will see you back in about a week from your surgery and get you started in physical therapy. Next thing we think about is nerve and artery damage. Good thing for us, all the big nerves and arteries in your knee are actually way in the back of your knee. And all of the work that we'll be doing when we do this procedure is on the front and a little bit on the side. Now, we have to make sure that when the surgery is done and you're recovered, that your kneecap doesn't continue to pop out of place. That's something that we do get concerned about. We want to make sure that you don't have continued pain, that you don't have any problems with future arthritis, and sometimes your cartilage can get damaged from these repetitive patellar dislocations. We want to make sure that when we drill the tunnels into your bone, and specifically your kneecap and your thigh bone, that down the line, those bones don't break, specifically your kneecap, because it's such a small bone. Also, whenever we do leg surgery or lower extremity surgery, we always think about blood clots. We don't worry about blood clots necessarily because in most young, healthy kids, the risk is pretty low and you'll be up and about with your crutches and such. So we don't always have to worry about that. Finally, we have to make sure that the screws that we put in don't break or pull out. We have to make sure that the bones heal, that the screws are trying to hold together. And then lastly, we talk about something called compartment syndrome. So that's where you have a lot of swelling in a different compartment, in a muscular compartment, um, that can cause a lot of pain and discomfort after surgery. And it's a little bit of an emergency because sometimes we do have to bring you back to surgery to release some of that pressure in the compartment. Again, we don't anticipate any of these complications, but these are some of the complications that I thought I would mention.